Here we have a cardiac function curve and a vascular function curve. And we have a moderate heart failure. Cardiac output drops because at the same filling, I have a decreased stroke volume. Okay? That's what you'd expect. And your cardiac function curve, your Starling curve, shifts downward, just like you would expect. That's the way we drew it up. Decreased inotropic state, decreased contractility, your curve falls. And you get less force of contraction at the same CVP. Well, if I have less force of contraction, less stroke volume, less cardiac output, what's going to happen to my central venous pressure? It's going to rise. It's going to rise because of my vascular function curve, and my central venous pressure goes up because my cardiac output drops because I drop to a new cardiac function curve. Now, because my central venous pressure goes up, my stroke volume goes up, and I end up at a new operating point. And what I want you to remember is the operating point moves to the new intersection. I drew a new cardiac function curve, and I have a new point of intersection with my vascular function curve, and that is the new operating point. And I'm going to operate at a lower cardiac output and a higher central venous pressure. Okay? Now, your system reacts to the lower cardiac output in ways that we will talk about in a couple more lectures from now by retaining fluid. Your kidneys actually retain fluid, and you increase the volume of the system. It's equivalent to a transfusion. And your vascular function curve shifts in parallel upward. And so your body reacts to the fact that you're in heart failure and that your stroke volume is dropped by retaining fluid and causing your vascular function curve to shift in parallel, just like I showed you. And now we have a new operating point, and you will notice that it is at 5 liters per minute, which is the normal cardiac output. So your system is compensated in part, by retaining fluid and causing the stroke volume to go up to a new operating point. Now, the disadvantage is that I'm at a higher CVP, and now my jugular is distending, okay? But the central venous pressure is something that your body is willing to increase in order to maintain cardiac output, okay? And so you get a parallel shift in your vascular function curve to a new operating point, and when you get back all the way to 5, you've compensated, okay? Here's our dilated cardiomyopathy patient. So you might think of her in these terms. She's got a nice dilated venous distension. However, her blood pressure is still not normal. So we may reasonably conclude that her cardiac output did not recover all the way to 5 liters per minute. It was probably lower than that. And as a result, her central venous pressure is even higher than our moderate heart failure. And she can't even get back up to 5. In fact, almost no matter how much you increase the central venous pressure, you won't get there. Because we're plateaued out, the heart can work as hard as it can, and it still won't make it to 5. So in severe heart failure, you're at a new operating point where you've dropped to a cardiac function curve that's even lower than our moderate heart failure, and our new intersection point's actually lower along this vascular function curve, and our CVP is even higher, and we've got even more jugular venous distension. Okay? Well, you may say, so what? Here's our blood pressure, cardiac output's probably down. There's our distended jugular with venous pulsation at the angle of the mandible, okay? So this indicates that we have a higher venous pressure, okay? Well, the patient also notes that her notes increasing lower extremity swelling bilaterally and can no longer fit into her shoes. She also states that she has gained approximately 10 to 15 pounds since her family visit 2 weeks ago, and this is, as it turns out, because she had a bunch of salt. So she went off her diet. Why would that be? Well, here's the problem with increasing venous pressure. It increases capillary pressure. Okay? And in fact, it increases it out of proportion when you compare it to how much arterial pressure increases it. We'll worry about that tomorrow. Okay? So let's go through what's happening at the capillaries. We have our arterial end of our capillary here, our venous end here. Blood is flowing from high pressure to low pressure along this capillary. And we have high hydrostatic pressure here, we have low hydrostatic pressure here, because this is the venous end. Okay? We also have proteins in our blood, mainly albumin, that can't cross the capillary wall, which means we have a higher osmolarity in the capillary. When we talk about that being due to large proteins, we talk about it in terms of oncotic pressure. We have high oncotic pressure. What that means is that you have a higher osmolarity in the capillary and you're drawing water into the capillary. Okay? And that's happening all along here, and the blue arrows represent the fact that water is flowing across this capillary wall from outside to inside due to the fact that the osmolarity in the capillary is higher, or water concentration is lower. Okay? And water diffuses across the capillary wall from high concentration to low concentration. All right? At the same time, we have relatively high hydrostatic pressure on the arterial side, and that is pushing water out of the capillary, okay? Because the hydrostatic pressure in the tissues is lower than the capillary, water flows out. So we have water going in because of the osmolarity in the capillary. We have water going out due to the fact that we have hydrostatic pressure pushing it out. So there's a delta P across that wall. So the net effect is defined by this equation here, which was in your self-study. If you look at the pressure, the hydrostatic pressure difference across the wall, and you subtract away the oncotic pressure difference across the wall, which is the driving force for drawing water in, you can ignore this sigma. It's called a reflection coefficient. It is, for our purposes, it is 1. Okay? And you get a net flow on the arterial pressure of water from the capillary out into the tissue. Okay? So the net effect of the high hydrostatic pressure and the oncotic pressure on that end is to push water out. On the venous end, hydrostatic pressure is lower. You have less pressure pushing water out. You have the same oncotic pressure, that is, you have the osmolarity still drawing water in. It does not change significantly over the length of that capillary. And the net effect is to draw water in on the venous side. So you have a net pushing of water out on the arterial side. You have a net drawing of water in on the venous side. Okay, overall, across the entire capillary, you get a slight favoring of outward, and that is where lymph comes from. You get slightly more pushed out than drawn in, and you get lymph. Okay? And the fluid, a little bit of fluid accumulates in the interstitium. Okay? If I increase the venous pressure a lot, I alter this balance, and I go from a little bit of lymph to a whole bunch of fluid accumulating in the tissues. Okay? So more venous pressure, higher capillary pressure, more filtration, pushing water out relative to reabsorption, bringing it back in. Her tissues swell, she can't fit into her shoes. Okay? So here's your bilateral pitting edema. That +3 is a rating. I'll explain that tomorrow a little bit, but it's a measure of the severity of the edema, and that explains why she's got it. Higher central venous pressure, higher capillary pressure, you get edema, okay? So it was not an academic exercise. I mean, I actually tortured you with the vascular function curve, but there's a reason for it. It demonstrates a concept. And the concept is that increased venous pressure, increased capillary pressure, this explains partly why you get edema. Okay? And the fact that your kidneys are retaining fluid in response to the failure does not help, because your central venous pressure rises even more then. Okay? It certainly helps maintain the cardiac output, which is what your body really wants. But the side effects can be fairly disturbing when they become severe. Any questions? We okay with that? You guys nod your head and say, I'm glad you talked about this. It sounds relevant. You didn't waste my time this morning. I didn't show up for nothing. Okay. Thanks a lot. I believe we have at least one lecture tomorrow, maybe two, and I know we have that hemodynamics workshop. I do encourage you to come, okay? It's in here. It's a whole class workshop. Go ahead.
Could you go back to the slide about the two graphs for cardiac output versus CVP?
That one?
Yeah. So would you say the more linear one is a function of like kind of the blood volume, and then the more, I guess, sigmoidal is a function of inotropic state?
I wouldn't say kind of. I'd say exactly. Okay? This is the cardiac function curve. We defined that last lecture. Okay? This is the vascular function curve. We defined that this lecture. Okay? Those are the curves that we defined. We just replotted the vascular function curve to put cardiac output on the same axis as the cardiac function curve. Okay? So there's no kind of about it. That's what it is. When you see a relationship where the cardiac output is going up with central venous pressure, that must be the cardiac function curve. And that's the one you change with inotropic state. When you see a relationship where the central venous pressure is going up as the cardiac output falls, that's the vascular function curve. And that changes with things like retaining fluid or changing the resistance. Okay? I see another hand. Go ahead.
Yeah. So for each instead of those two curves, there's only one possible point. So what happens when you change venous pressure?
Well, it just goes up and down, but eventually it comes back down to the same point. Okay? I mean, you know, this is with a defined compliance and everything else and no reflexes. So, you know, assuming that you're not doing anything permanent, it's just temporary, eventually when the system comes to steady state, this is where it'll be. Okay? I really don't know how you do that, but there must be a way. This is where it's at. Go ahead.
Is it fair to say that the set point is function curve or is vascular function curve?
No, it's not fair to say that at all. It's determined by both. It's the intersection between the two curves. Okay? There is no, it's determined more by one than the other. It's just determined by them both. Okay? Anything else? Go ahead. Well, here's the relationship. This is your vascular function curve. Cardiac output goes down, central venous pressure goes up. You can see the line. Here's our cardiac function curve. Central venous pressure goes up, cardiac output goes up. That's the relationship. Was there something else you wanted? Maybe you need to think about it. Study the notes and think about the lecture, and hopefully it'll make a little bit of sense, okay? There's a case study that pretty much says what I said on this graph, okay? And give it a little thought. I really can't define the relationship any better than that. I mean, I could repeat the whole lecture. I don't think we want that. I definitely don't want it, because I workshop. Go ahead.
So you said the increasing cardiac output, as that increases the central venous pressure, that's called the cardiac function curve? Right?
That's right. It's the Frank-Starling curve, but it's cardiac function curve. It's the same thing. Stroke volume goes up with central venous pressure. That is, it goes up with filling, okay?
And
vascular function curve. Okay? And that was really the purpose of this lecture, defining the vascular function curve. I wouldn't think so much in terms of shape, like it's sigmoidal, so it must be cardiac. Look, you know, central venous pressure goes up, cardiac output goes up. That's the cardiac function curve. Okay? And if the opposite happens, then that's the vascular function curve. Okay? Anything else? Got 5 minutes. Okay?